Hello, everybody. Thank you for attending our webinar. And today I would like to show some examples how maintrac and stemtrac can be used during the clinical course of your patients in clinical practice. We all know that the formation of metastases is the most threatening aspect of malignant tumors. Most malignant tumors are of epithelial origin. And how can those metastases develop? We know that carcinomas disseminate cancer cells into lymph and blood, and these cells can then be released at another organ and form the metastases as shown in the left picture. We call these cells not CTCs, but CETCs, circulating epithelial tumor cells, because the maintrac approach only can detect the epithelial cells. But I will show also that cells with stem cell characteristics, which may sometimes not express epithelial antigen anymore, can be detected by the stemtrac assay. So we would subsume our method among the liquid biopsies, which means a minimally invasive procedure that allows detection, and in our case of living circulating tumor cells, living cells that are detected in peripheral blood. What can we perform with this approach? We can count the cells over time and then show trajectory of the cell numbers. We can test them for therapeutic substances, whether they are sensitive to these substances. We can also show whether these cells carry therapy-relevant tumor characteristics, which may be important if certain therapies are applied. And we can show the most threatening cells, the stem cells, by growing them into tumor spheres. We detect these cells by their EpCAM surface antigen, which can be detected by a fluorochrome antibody against these surface structures, and we can detect them without enrichment among the other white blood cells. The approach can be used for all solid epithelial tumors. It's fast and reproducible, and it is performed in a DIN ISO 15189 certified laboratory. How do we proceed? We get the samples from you. Then the only step which is performed is lysis of the red blood cells, which are 1,000-fold more than the white blood cells. Then we spin the white blood cells down, and this can be seen with this tiny little sediment. And subsequently, we label the cells with the antibody as shown before. Then the suspension is transferred into a 96 well plate, and we have a special microscope which scans over these wells and detects the green fluorescent cells and shows them to us. And from these numbers, we can then draw a trajectory over time. These cells are more frequent than in other approaches, and we show here the cells from one patient. The right upper cells are the cells that we count. They are living. We need to see a nice nucleus, but the staining can be quite different over the whole cell or a tiny staining on the membrane. In the middle gallery, that's cells that also are green stained, but they do not have a nice detectable nucleus, so we avoid them. And in the left lower gallery, that's the cells which we see are dying because their membrane is porous, and a red fluorescent dye can enter and stain the nucleus. And this is a sign that the cells are dying, And we omit these cells in the cell counting, but during sensitivity testing, this is important for us to have these cells, count them too. We give the numbers of cells, of EpCAM positive cells, as numbers per volume, mainly 1 ml. The middle gallery is in the whole blood of a person. And the interpretation is 50 is minimum number of circulating epithelial cells. 50 to 100 is a minimal to slightly elevated number. 150 to 400 we call slightly elevated. 450 to 550 is low to moderately elevated numbers. 600 to 2000 moderately elevated numbers, and more than 2000 is considerably elevated number of circulating cells. So you can estimate how we call these numbers. So another approach which I have mentioned is the stemtrac approach to assess tumor aggressiveness and the risk of metastasis. The stemtrac tries to track cells with stem cell characteristics, which are among the circulating tumor cells and sometimes are only a small population of the circulating tumor cells. They have typical stem cell characteristics with self-renewal capacity, and daughter cells can also differentiate into heterogeneous populations, again, of cancer cells. And they are thought to be responsible for initiation, progression, recurrence, and metastasis. It's known that they obviously may be resistant to most conventional chemo and radiotherapy, and therefore most of the current treatments are not effective against these cells. And therefore, strategies to eradicate these stem cells are an urgent topic in cancer research. We have published a method how to culture these cells from the peripheral blood into tumor spheres, and I'll show how this is done. So we again receive the blood from you. We again need to lyse the red blood cells, and we have this tiny white blood cell sediment. And now we put these cells into culture. And if there are stem cells present, they develop into small spheres, into 3D structures. And this type of growth is known to be typical for cancer stem cells. In addition, we can analyze these spheres, and they need to be EpCAM positive, even sometimes if they have developed from EpCAM negative cells. They are typically CD24 negative or low positive and CD44 high positive, and express the LDH1, which can be tested in a special enzyme test. So we think our method is mainly designed to monitor therapy. And I'll show examples. We think that this approach makes it possible to monitor the therapy and directly observe tumor activity, and thus is an additional tool for optimized and personalized therapy. So this is one example of a patient with estrogen receptor positive small tumor. She received neoadjuvant chemotherapy with doxorubicin, cyclophosphamide, and docetaxel, and she had a very good response, and you can see that cell numbers decreased during this treatment. She then had surgery, and as you can see, there was a small increase in cell numbers subsequent to surgery, which we often observe. She then had radiation and now has tamoxifen until current. So in addition to a good clinical response, long-term follow-up shows that cell numbers remain relatively constant with a dip into it between, which we cannot explain at the moment. First, there were low or undetectable numbers of circulating stem cells, but after this dip and the re-increase in circulating cell numbers, also the circulating stem cells increased, and that's why we think the patient should be frequently monitored during further tamoxifen treatment. Another case, this was also a patient, a young patient with breast cancer, also estrogen receptor positive, and she received surgery before chemotherapy. We didn't monitor the numbers before surgery, but during adjuvant chemotherapy with doxorubicin and cyclophosphamide, and then 12 times paclitaxel, we saw an increase in cell numbers. And this indeed did precede bone metastases, which were then detected about 1 year later. She then received therapy with abemaciclib and fulvestrant, and cell numbers decreased. And this is a little bit wrong. The lymph node metastases were seen after this increase in cell numbers after the end of abemaciclib and fulvestrant. And she then received carboplatin and paclitaxel, whereupon cell numbers decreased. She showed a good clinical response, and we observed a decrease in circulating epithelial cells, but she still has quite a lot of circulating stem cells, and therefore we think it's necessary to monitor her closely during her therapy now with paclitaxel. This is another patient who had a triple negative breast cancer, a very young patient. She again was treated with neoadjuvant chemotherapy, doxorubicin, paclitaxel, and in addition, the pembrolizumab, an antibody checkpoint inhibitor. We didn't monitor her before, but she then had surgery and radiation, and at that time, she had quite high cell numbers. She then received pembrolizumab with capecitabine. During this time, her cell numbers still increased, but they now do decrease after the end of the checkpoint inhibitor. Stemtrac, which was only performed recently, showed elevated circulating stem cell level, and therefore the patient should remain under close monitoring. And this patient, she was an elderly woman who had a triple negative cancer, but was PD-L1 positive. So she received neoadjuvant chemotherapy with doxorubicin and again with the checkpoint inhibitor pembrolizumab. She had only partial response, which we would like to see complete response in triple negative patients, and had surgery and subsequently radiation. We only analyze her during the subsequent adjuvant immunotherapy, again with pembrolizumab, and she had very high numbers. She then showed subsequently a local recurrence, which was removed, and we analyzed the cells only after this surgery, and there we could see low numbers in circulating epithelial cells and low numbers in stem cells, but additional immunotherapy is currently under consideration. So after these cases, do you have any questions?
Just a comment here. These presentations, the scales of those is a logarithmical scale. So sometimes the increases or decreases don't look like much if you just follow the line, but these are logarithmical scales. So if you have a look back at them. In the first case with the patient with the breast cancer, the question is, why was it chosen to check for stemtrac or for circulating cancer stem cells at that point?
Why was it chosen to look for stem cells?
Yes.
because we assumed that tamoxifen might be able to silence the stem cells. And indeed, for some time, it was possible. The stem cells remained undetectable, and we still do not know why there was this increase. We would need to inquire, was there some special event which led to the re-increase of the circulating cells and the circulating stem cells? So thank you for your attention, and you can send an email to our laboratory or to maintrac.com.